I think everybody here probably knows our very own Cherie Bochenko. Really happy to have you present today. So Cherie is a graduate of Amherst University. She has a business degree from there, and then afterwards she went on to complete her APRN studies she was at the University of Hartford and then St. Joe's. So she's here with us in PCU right down the hall from me. So very happy to have her present today. So I'll hand it over to you.
All right, thank you so much, Dr. Podolsky. So I work in primary care unit at the Root Center, and very excited about my job here. I love working in addiction medicine. And so I was thinking about, mood disorders and addiction. And so I'm going to try not to overlap too much when I'm talking about the subject, but as you'll see, they're very much intertwined, especially in the population that we serve. So we're going to go over, let's see. So the objectives for today will be first steps to treatment. We're going to review common mood disorders. Review how substance use disorders and addiction can mimic mood disorders, screening tools, diagnostic testing, treatments, and some barriers to treatments. Now, I'm going to try to keep track of the chat box, but forgive me if, toward the end, if you're writing to me, I'll certainly get to any of those questions at the end or comments. So actually, this is a good reminder for me to put on my own glasses. But in this presentation, I'll refer to people with mood disorders or substance use disorders as patients, because we're seeing patients in primary care, but some of you might call them clients. As we're reviewing mood disorders and addiction, I'd like for us to look through the lens of patient education. I'm going to stay away from going into too much medical or technical. That nitty gritty on the cellular and chemical level, that's its own presentation, and I can provide some resources. But I've thought a lot about how can we, provide a good explanation as to what's going on in a person's brain when there's a substance use or addiction or mental health issues. As providers in all different ways, we engage with patients, and it's very important for us to be able to present the information that makes sense to them, while instilling a sense of hope and encouragement in the treatment. So this is nursing, right? A medical background. We're always going to rule out medical conditions. Medical conditions can mimic symptoms of mental health disorders. Before a diagnosis or treatment, we really should conduct a thorough diagnostic evaluation, including an interview and physical examination. In some cases, a blood test might be done to be sure that depression is not an underlying medical condition like a thyroid problem, pernicious anemia, or vitamin deficiency. And reversing the medical cause often alleviates the symptoms of depression-like symptoms. The evaluation will identify specific symptoms and explore medical family histories, as well as cultural and environmental factors, with the goal of arriving at a diagnosis and planning a course of action for that patient. Of course, when we're going to advise treatment, when we're meeting with patients, when emotions are interfering with work, relationships, social activities, or other parts of our lives, if there's trouble drinking or with drugs, any suicidal thoughts or behaviors, of course, that's an emergency, treatment is needed. So when I first started out, we all love that DSM-5, the nose is in the book. I caution you, don't bring it to holiday gatherings, but we have to resist the urge to kind of put patients into certain criteria when it's not always going to fit. We have to remember that diagnostic criteria are not the diseases themselves. They're a starting point in understanding the conditions that we treat. While important, the criteria are a little like treasure maps and getting to know the patient. They'll never bring us closer to understanding a patient's experience, but when used in combination with patient history and thorough clinical evaluation, we'll get closer. And of course, I love to throw in a treasure map. And I think it's important to remember that most patients want to tell us their story. A patient's narrative and natural history can give providers a wealth of information. So what is a mood disorder? It's a mental health class that's used broadly to describe all types of depression and bipolar disorders. And when you really get into the list, it can be kind of confusing. Many factors can contribute to mood disorders: genetics, imbalance of brain chemicals linked to disruption in the brain's reward circuitry, stressful life events, health conditions, substance use disorders. Mood disorders can be chronic, but are treatable. It's very important to impart this message to the patient that, look, there's a lot of different options here. And then I always like to explain, hey, this depression, it's a medical condition. This is not a personal flaw or a weakness. And there are lots of ways that we can treat it. This word cloud is just, I took all of the mood disorders and I put it in there. And so it's a lot for one presentation. So I'm just going to pick, choose the highlights. We've seen major depression, bipolar disorder, but there's a major depression, bipolar, seasonal affective disorder, cyclothymic disorder, premenstrual dysphoric disorder, persistent depressive disorder, also called dysthymia, disruptive mood disorder, dysregulation, depression related to an illness, and depression related to substance use. And that can be overwhelming. So we're going to see the most commonly ones that we see in our clinic: major depression, bipolar 1 and 2. There could be mood disorders related to a health condition, and substance use related mood disorder. Now, if you look in the DSM-5, there are symptoms, and there's 5 or more symptoms that have been present in a 2-week period and represent a change from previous functioning. At least one of the symptoms is either depressed mood or loss of interest or pleasure. Depression is the highest lifetime prevalence of any single psychiatric disorder, with 20% of all people experiencing a depressive episode in their lifetime. Major depression occurs without a history of manic, mixed, or hypomanic episodes. And care must be taken not to include symptoms clearly attributed to another medical condition or a life situation. Responses to a significant loss, such as bereavement, financial ruin, losses from a natural disaster, serious medical illnesses or disabilities, may include feelings of intense sadness, rumination about the loss, insomnia, poor appetite, weight loss, and they all might represent, a depressive episode. So that's why it's really important to get a good history and physical from the patient. And when we're going to rule out hypomanic and manic episodes in depression. Now, understanding depression, that's a tough one. Even when you're trying to explain to patients, it's poorly understood. The current treatment is based on what's called the monoamine deficiency hypothesis, and there are some emerging thoughts about what's actually going on in the brain. And it's, we're talking about 1 of 3 neurotransmitters in the brain is deficient or underactive, and they all may play a role. When I talk to patients, we talk about that there may be there's a strong evidence of a genetic component to depression, but specific genetic factors have not really been identified. We talk about the fact that, there are changes in the brain. Research shows that the hippocampus is smaller in some depressed people. Most currently used antidepressants have been considered to act on the basis based on the monoamine hypothesis. What research tells us right now is that on a chemical level, depression involves neurotransmitters. We won't go into great detail here. There's going to be some overlap when we talk about substance use. So major depressive disorder, mnemonic is 2 blue weeks with the SIGGI caps. So it's positive for depressed mood, sleep, either too much or too little, an interest deficit, person's not interested in things that they might have been interested in, guilt, feelings of worthlessness, hopelessness, regret, an energy deficit, concentration deficit, appetite, either too much or too little, psychomotor slower, and thoughts of suicide. And it's important to note that depression may manifest differently between men and women. Women with depression are more likely to report physical ailments such as headaches, myalgias, or GI problems. They're also more likely to exhibit emotional effects such as stress and crying easily, while men with depression are more likely to report acts of aggression, anger, substance use disorder, risky behavior. Some screening tools. There are lots of screening tools for depression, for any mood disorder. In primary care, we can use the patient health questionnaire, the PHQ-2, which is 2 questions, or the 9, which is 9. They're self-administered. They're really great tools. They don't really take very long for a patient to answer. Hamilton Depression Scale takes a little longer, 20 to 30 minutes, but it takes into consideration somatic symptoms. And the Beck Depression Scale, it uses self-rating. It usually takes 5 to 10 minutes to administer. Any positive results from depression will definitely, from the scales, will definitely warrant further investigation. Let's see. So bipolar disorder, it's still a depression, but it includes alternating times of depression and mania. Bipolar 1 is characterized by an occurrence of 1 or more manic episodes or mixed episodes. Bipolar 2 is characterized by the occurrence of 1 or more hypomanic episodes. And it's important to know the difference, right? Because in bipolar overall, we're going to use caution with medications, right? So we don't want to treat a person with bipolar highs and lows with certain medications, which could actually increase the frequency and duration of the person's mood episodes. We're not going to go into great detail about mood disorders, like, the nitty gritty of what's going on and what the criteria. We're going to really focus on how mood disorders and substance use disorders are kind of an addiction are intertwined. Here's another little helpful mnemonic. This is for bipolar, dig fast, and you can imagine a person digging frantically to get to something that we don't know. They're digging a hole. The person is distracted, indiscretions, right? Excessive pleasure activities, grandiosity, flight of ideas, activity increase, sleep deficits, talkativeness. Hypomania is the same as mania, except it lasts 4 consecutive days, and the unequivocal changes rather than a marked impairment. Some great screening tools for bipolar disorder. Some are going to overlap with depression, but the mood disorder questionnaire is really great. 5 minutes to complete, and it's really used very often. And it will really depend on your setting as to what your organization has decided on to settle on for screening tools. Mood check, bipolar spectrum diagnostic scale. We could track symptoms through the Young Mania Rating Scale, and of course there's a Prime MD and the PHQ-2 and the 9. So treatment approaches will just cover just in general for mood disorders. I mean, the goal of treatment here is to eradicate or really reduce the symptoms of depression. We want to help improve that person's daily functioning, quality of life, improve relationships, workplace, reduce any symptoms of suicidality, and we want to minimize adverse effects and prevent relapse. Therapy is really the foundation, of good treatment for mood disorders. It's the first line option for mild to moderate depression. When there is severe depression on board, we're probably going to be heading right toward medications initially to help stabilize that person. The most commonly prescribed medication to treat depression are antidepressants, SSRIs and SNRIs. They offer a similar response. They could be used as the first line as monotherapy in mild to moderate depression, but definitely, you might be adding some complementary medications to manage that person's symptoms. So what is addiction? I mean, addiction is not really that hard to diagnose as long as we know about it. It's treatable chronic medical disease. And I make sure the patient knows that you have to treat this. This is a medical issue. I recently saw a patient with thyroid hypothyroidism, and I asked her if she blamed herself for her hypothyroidism. And she's like, "What? Are you crazy? No, I had nothing to do with this." Now, it's a little bit of a difference in substance use because patients feel that they've had a choice, right? But nobody would choose to go through this knowingly. And so I really spent a lot of time talking to patients that, look, this is a treatable medical disease. And if you can, you can take some of that burden off of your shoulders and then get to the treatment. So it's complex interactions among brain circuits, genetics, the environment, the individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And generally, there's the approach of the 3 R's and the 3 C's. If they're all present, then there's probably an addiction. The R would be repeated use, positive reinforcement. The person gets some reinforcement out of the issue and the addiction. And then they're using despite negative repercussions. The brain is a different brain when there's substance use. And I like to tell patients that this is a condition about brains, not drugs. And it's important a lot of times with patient, the withdrawal part of the addiction is found to be more motivating than the use of the high. You're really just trying to run away from that withdrawal. Prevention efforts and treatment approaches for addiction are generally as successful for those as other chronic diseases. It's important to know that the patient know that treatment of addiction, I mean, it's a choice to get treatment, but the addiction itself is not a moral failing. So some treatment approaches for addiction. For alcohol, depending upon the severity, we might, of course, recommend detox because people can die from actually alcohol and benzo detox if they're doing that at home. Some medications commonly used, naltrexone, acamprosate, antabuse. For opioid use disorder, we're here at the clinic here, we're using methadone, Suboxone, Sublocade, Vivitrol. Patients might come in directly here for treatment, or they might be referred by detox or maybe hospital. And then it's really important to make sure the patient knows, individualized or group therapy is very important. IOP, Narcotics Anonymous, AA. And so there are some emerging treatments for alcohol use disorder. We might use the anticonvulsant topamate or Topamax. Some SSRIs might actually have demonstrated some efficacy on alcohol dependence. Baclofen has been used for alcohol. There is definitely for the science demonstrating the effectiveness of medication for opioid use disorder is very strong. Methadone, naltrexone, whether it's oral or injection, and buprenorphine have found to be more effective in reducing illicit opiate use than no medication in randomized clinical trials. This doesn't mean that remission and recovery occur only through medication. There's lots of supports needed for success. It's not listed here, but I'll touch on cocaine. a lot of the patients that we see here also suffer cocaine dependence. It's associated with numerous medical complications. Treatment options are limited. There's no agreed upon drug treatment for cocaine addiction. There are some off-label uses, and I'll often mention it to a patient that if you're really struggling with cocaine dependence, you might want to meet with mental health provider to talk about some medications that can actually help with cravings. Sorry about that. Let's see. Okay. My apologies. And so it's really important to educate patient, when you're in recovery. So you say they're here for opioid use disorder. It's important to know what's happening chemically, that when cocaine is used, it's kind of like Pac-Man, and it eats up, it metabolizes that methadone. And so a patient will really never be able to get to that therapeutic dose of methadone. So what came first? Really hard to know. Substance use and mental health are really closely tied, and one really can't be evaluated without knowing about the other. Specific drugs can masquerade as a variety of mental health conditions, but many mental health conditions can also be triggered or exacerbated by substances. Patient education is very important here. Patients might not be forthcoming about substance use or maybe downplay the use. When we see people in primary care unit, it's really hard to say, oh no, there's no use here, because we are testing for alcohol, and then we're doing a urinalysis, so we're able to tell. But even our own patients will come in and they'll downplay the use of their cocaine or fentanyl. And one of the drugs that we have a really hard time getting information on is like alcohol use. And so it's really, even in a primary care setting, if an average person goes for an annual physical, they might actually downplay how much alcohol they drink socially. So it's really important to develop that therapeutic relationship with that patient. There's some trust there. Patients, it's very important if they're getting outside mental health treatment. I will ask them, does your mental health provider know about your opiate or your alcohol use? And I can't tell you how many times that they've said, no, I'm too embarrassed, I'm ashamed. And that's the time to give some patient education and just letting them know that your mental health provider actually won't be surprised, because it's very common. Up to 60% of people with opioid use disorder also have mental health issues. So very important to kind of normalize that conversation where the patient is not hiding it, and just letting them know that they'll be able to get the best treatment available if they share everything that's going on with them. So symptoms of mood disorders or substance use disorders. So I got this actually right from the DSM-5, and this is for mood disorders. But when you go to the substance use disorder section, it says, hey, this is a differential diagnosis. So we'll see this with our patients, even if they claim not to have any mood disorder. They're sad, anxious, empty mood. They feel hopeless, low self-esteem, inadequate or worthless, excessive guilt, repeating thoughts of death or suicide. Very important to do that kind of screening and get help for that patient. It's an emergency. Loss of activities, relationship problems, trouble sleeping, too little, too much, changes in appetite or weight, decreased energy, trouble concentrating, unable to make decisions, frequent somatic complaints, headaches, muscle aches, irritability, hostility, or aggression. It could be, so it's kind of hard to parcel out what came first, and a good history can certainly help that. Now, is it a substance-induced or a mood disorder? And that goes back to history. We can, findings from history, physical, lab findings. Is the mood disturbance not better explained by a depressive or bipolar related condition? Symptoms precede substance or medication use, or symptoms persist after a substantial period of cessation or acute withdrawal or severe intoxication. And physical findings can present as signs of use, IV injection sites, bruising. Labs can show illicit drug use, or, when we are doing lab blood work, we can see some underlying, maybe some problems with liver functioning, or, underlying other conditions. It's very important to do a thorough exploration, even when there's even an inkling of substance use. For substance use history, we're at minimum, we're going to ask patients if they drink alcohol in certain settings. I mean, we're asking, this is a primary care for people who have substance use. So we're delving into all the use for different classes of of drugs. We want age of first use, treatment, history. We're going to screen for mental health disorders, history of medications, hospitalizations, trauma, legal history. We're going to do a full substance history, and that's part of admission to opioid use treatment, is to establish that history. And substance-related disorders encompass 10 separate classes of drugs, and some of them are legal: alcohol, caffeine, tobacco, cannabis, hallucinogens, inhalants, opiates, sedatives, hypnotics, anxiolytics, amphetamine type substances, cocaine. So the important part here is that all drugs taken into excess have common direct activation on the brain reward system. So I feel like the photo does a very good job of saying, like, what is this? There is a comorbidity between substance use and mental health disorders. There are common risk factors. Both substance use disorders and mental health illnesses are caused by overlapping factors, genetics, epigenetics, vulnerabilities, issues with very similar parts of the brain, early exposure to stress or trauma. It's estimated that 40 to 60% of an individual's vulnerability to substance use is attributed to genetics. Many areas of the brain are affected by both substance use and mental health issues. For example, the circuits in the brain that mediate reward, decision-making, impulse control, and emotions may be affected by addictive substances and disrupted in substance use disorders, depression, and other psychiatric disorders. In a couple of slides, we'll go over a little more about the dopamine reward system. Okay, so some great screening tools. We have the Assist. It covers alcohol, smoking, any substance involvement. The Audit, A, which is a 10-item screening tool. The Audit C, which is 3, and these both are more alcohol consumption. We have the CAGE. It's a non-confrontational questionnaire for detecting alcohol problems. The S, opiate risk tool, and it will really depend on what your setting is as to what kind of screening tools you'll be using. These tools are just another way to connect with the patient. So the brain reward pathway, it can be very confusing, and in the beginning, I used to try to explain it to the patients. And if there's no medical background, it's really hard to understand really what's going on. The reward system reinforces important behaviors that are essential for survival, stimulated normally by food, water, sex, social interaction. It begins in the VTA, which is the midbrain, and it primarily produces and releases dopamine. The amygdala and hippocampus play a role in emotions, right? We're going to remember the happiness and whether the experience was desirable. The nucleus accumbens contains dopamine sensitive cells, which is really crucial to this whole reward system. The prefrontal cortex coordinates all the information and determines the behavior of the individual and impulse control. The pathway is the same for alcohol, opiates, methamphetamine, nicotine. And so I like to kind of explain it to a patient. For example, the reward system ensures that you reach for food when you're hungry because after eating you'll feel better. You'll feel good. It makes the activity pleasurable and memorable, so you want to do it again. And it can really apply to anything. Really healthy things and not so healthy things. So here's the picture of the brain. In the addictive brain, drugs hijack the normal learning pathways and activate reward systems in response to drug-associated cues, which leads to cravings and compulsive drug-seeking behavior despite harmful consequences. All known addictive drugs reward regions in the brain, causing a sharp increase in the release of dopamine. Some drugs are more powerful stimulus than other, such as stimulants, cocaine. Major depression is associated with abnormalities in the same reward-related brain structures, such as the nucleus accumbens, the prefrontal cortex, amygdala, and hippocampus. Changes in the activity and functional connectivity of these sites lead to abnormalities in the perception and interpretation of reward valence, in the motivation for rewards, and in subsequent decision-making. The nucleus accumbens, amygdala, and hippocampus are part of something called the mesolimbic pathway, which is part of the reward system. We're just going to hit the highlights here. These terms and processes can be broken down even further, and but then we move away farther from how we talk about this with the patient. When dopamine goes up, activating dopaminergic circuit, this reward circuit causes continued pleasure. When dopamine is up, serotonin goes down. And serotonin is partially responsible for feeling satisfied, satiated, or content. And this can be confusing when you try to explain this to a patient, and especially on a day where they're coming to primary care, they might not actually be feeling very well. And, it's definitely helpful to, I try to explain it in a way that's going to make sense. So what I usually do is when I talk to the patients, I describe what's happening in the brain by drawing a very bad picture of a head. So I'll draw a picture of the head with the brain. I tend to oversimplify it, and I let them know that I feel like it's helpful for you to know chemically kind of what's happening in your brain. And for some of my colleagues, you'll know that I really love some of the podcasts, and I'll put it in at the end. Addiction Files and Anatomy of Addiction do a really great job of kind of explaining in easy to understand terms of what's happening in the brain when there's addiction, and it can also be applied to mood disorders. So I mark out the three areas of the brain, kind of like the three brain kind of model. The old brain, or the primal brain, is located in the back of the brain, right? And it allows us to survive and evolve. And I usually will go into like a caveman kind of voice, and it says, eat, sleep, procreate, right? And we talk about that it's feeding, fleeting, fighting. We call it the prehistoric or reptilian brain. I like to refer to it as the caveman. The frontal lobe, when I talk to the patient, I said, that's your executive director. That's what brought you here today. This part of the brain says, hey, it's responsible for rational thinking and impulse control. The middle part of the brain is the heart of the rewards reinforcement, right? So there are a lot of chemical reactions, things going on there. When things are going well, we're feeling comfortable, safe, secure. And we can kind of call it the frat house part of the brain. And in substance use disorder, when stimulated, the caveman or the reptilian brain sends a message to the frat house when it receives that dopamine. Hey, this is fun. Let's do it again. In fact, let's keep it coming. Most people have heard of Pavlov's dogs and the triggering of the treat. So it's kind of similar to that. When this happens, the executive director comes in, the boss, and says, hey, this is great, but let's be rational. Slow down. Don't have another. Don't do it. It's dangerous. And we have responsibilities. And I'll say to the patient, your executive director, boss, brought you here today, right? You have to take care of this opiate use disorder. When when this happens and the frontal part of the brain says, hey, we have to take care of this, the caveman's message gets stronger. And then it kind of overpowers the executive director, and the boss falls asleep, takes kind of a back seat. And it's a good way to kind of explain, what is happening with impulse control. So, the frontal part of the brain, the boss controls impulse. And it's great to kind of explain it to your patient, or client. In the morning when you wake up, you promise you're not going to do X, Y, and Z. And any one of us can give examples. My example is, I'm not going to buy a pair of shoes because I really don't need it, but it's in my mind. And before I know it, I've done it. The shoes are on the way and they're going to be on my steps. In the case for opioid-induced disorder, person has promised, I'm not going to do this thing. And then at the end of the day, they're doing this thing. And it's like an aha moment. Sometimes we're talking to patients, that they're like, oh my gosh, it is. It's like I'm not in control of my own brain. And it's helpful for them to know, like, here is some underlying with it's obviously, more complex with all the chemicals and the neurotransmitters. Here is like something that is happening that is a little more easy to understand. This is where the compulsive use and feeling of loss and control comes in. There's a powerful association between substance and survival in the brain. And this is the message that the patients will get. You need this substance for survival. Now, not as simple as that. And we talk about, that when you stop using those pathways over and over and over again, when you go into treatment, now we'll usually draw out like little branches, like the neuroplasticity of the brain. When you go into therapy, group work, you have medication maybe to treat, anxiety or depression or any other mental health issue. You start doing new things, you get into a healthy routine. There are going to be connections that expand out into the brain that can make a more robust, recovery. And I like to mention that about therapy, especially because patients will say, oh, blah, blah, blah. I don't want to go to therapy. That does nothing. I'm just hearing myself or someone else talk. And I say, well, wait a minute. No, there's research that shows when you engage, there's actually things happening in your brain, and it's going to make your recovery more successful. Now, part of this whole thing about this little reward system here, as an aside, I always like to mention cigarette smoking to patients because nicotine loves this relationship. And I'll say, Nick, he's a liar. He's a liar, and he's going to tell you that everything is so much better with me, that you should keep it going. So even if you're not using illicit substances or drinking alcohol, there's always like a little echo there. Come on, we can all be together again. So patients are kind of surprised that, oh yeah, when I use or when I drink, I do smoke a lot more. And actually, yeah, things are better with nicotine, coffee, food, sex, use. And so I really do encourage, let's look at that nicotine use because you're going to be more successful. In some studies, patients who look at their nicotine use and get rid of it are 25% more successful in their recovery. So diagnostic testing, before you're in treatment with medication, we want to, we definitely, before we're starting, we want to do CBC, thyroid, vitamin D, toxicology, liver function, fasting labs, and lipid and glucose. It's important to, when we're adding medications on, and medications, SSRIs, SNRIs, atypical antipsychotics, typical, they can all have some side effects. And so mostly what we're concerned, we want to monitor for signs of metabolic syndrome. Metabolic syndrome is a cluster of conditions that occur together, increasing the risk of heart disease, diabetes, stroke. The conditions include increased blood pressure, high blood sugar, excess body fat around the middle. And so sometimes we're taking a measurement. Abnormal cholesterol, metabolic syndrome is also considered a pro-inflammatory. It's important to know about liver function, especially in the older population and with people with substance use. Impaired liver function could really limit the types of medications we're going to use to treat. So lots of behavioral therapies. I'd like to shout out to the therapists out there. Therapy, as I talked about before, promotes neuroplasticity in the brain. You know, we have all kinds of therapy, CBT, DBT. There are ways to talk to a patient, motivational interviewing. There's antidepressants, mood stabilizing medications. We're going to probably use more so in someone who has really fluctuating moods, maybe bipolar, or other psychiatric conditions. We have antipsychotics, typical and atypical, sleep. And all of these are good, and especially when combined with therapy. We're actually offering some treatments for treatment-resistant depression. So in Middletown, we're doing Spravato. We are starting gathering what we're going to be doing with transcranial magnetic stimulation. There's electroconvulsive therapies available. There's, you know, community support approaches. There are a lot of different approaches to treatments. You know, there's other therapies not mentioned, you know, family therapy, the group therapy, the EMDR, exposure therapy, interpersonal therapy, animal assisted, mindfulness. The list goes on. And I know sometimes our hands are tied based on what can be available to the patient based on, you know, access and funding. But it's nice to know there's a variety of tools available, and we can kind of, you know, tailor it to that person. Managing mood and stress, you know, chronic stress contributes to a range of health problems, including mental health and substance use disorders. So, you know, when I'm meeting with patients, I do talk a lot about meditation, you know, mindfulness-based stress reduction. We started doing acupuncture here a couple of weeks ago in Henderson Johnson, and we're very excited about that. We did it years ago, but now we're bringing it back. Massage can help. Food, you know, diet, like a low inflammation diet, exercise, or restful sleep, all of those are very important to recovery, whether it's addiction, substance use disorders, or mental health disorders. Some common barriers to treatment, you know, limited availability and affordability, insufficient healthcare, you know, mental health care policies, lack of education, the stigma, there could be confidentiality concerns. There can be challenges. I mean, you know, integrating mental health and substance use treatment in a primary care setting. Some patient barriers might be motivation for change, homelessness, substandard housing, transportation barriers. I mean, we're very fortunate at the Root Center that we have a lot of these services available. It's a huge advantage to know even that our population, when they're meeting with our mental health providers, it's a huge advantage for us to know that they have opiate use, cocaine, any of the, you know, any substance use, because that gives us kind of a leg up to devise a better treatment plan. Any questions?
Hey, Cherie, I had a question. Is with treatment for depression, is like the efficacy of the treatment influenced by if a client is like having a depressive episode because of like a tragic event or kind of life events versus a client that like has biologic genetic disturbance or kind of like long-term chronic? You know, like, is the treatment different?
It could be a little different. It might be, you know, if someone has a tragic event, of course, we're going to, you know, recommend therapy and supports and those kinds of things. And then sometimes it is needed for maybe short term to have, you know, maybe a shorter term treatment, especially if they have not had any previous, you know, anxiety, depression, anything like that. Yeah, it could be a shorter term treatment because sometimes depression is situational, and you can still, of course, you can still treat it to help the symptoms. But the treatment plan might be a little different, right? Might not be as long. You know, some folks are being treated lifelong, and other folks might be treated, you know, for a period of, you know, months to a year. It really depends on on that individual.
Well, if we have no more takers, thank you, Cherie. That was a wonderful presentation, very thorough.
Thank you so much for your time, everyone. Really appreciate it. Take care.